I'm Dr. Srivastava, consultant pediatric nephrologist at the Apollo Indraprastha Hospital. I'm talking about the management of nephrotic syndrome. This is mostly a talk about the management and not so much about the mechanisms and mechanics of it. There has been a lot of research and development in the understanding of proteinuria and the role of podocytes and the glomerular capillary filter, but so far we do not know the exact etiology. Nephrotic syndrome is a common problem in children. It requires long-term expert management, but in most cases complete recovery takes place. With proper treatment, the complications can be avoided and normal growth and development of the child ensured. The family needs constant emotional support because in most cases the condition lasts for several years. When we see a child with nephrotic syndrome, the chief feature is edema. Edema is slow to develop, comes on gradually, but it can be mild to massive in the beginnings and often mistaken for some other condition. In a few cases, the child may have hypertension. The main finding is heavy proteinuria, which on routine testing comes to like 3+ or 4+. Occasionally, there may be microscopic hematuria. Blood examination shows hypoalbuminemia and hyperlipidemia. Mostly the blood urea and creatinine levels are normal. Now, when we see a child, we have to find out if there is some underlying disorder which may be causing what we call as secondary nephrotic syndrome. These are uncommon, but we have to exclude these. And some of the causes are like congenital nephrotic syndrome, torch infection, the Finnish type nephrotic syndrome, congenital syphilis, we don't see these very much now, systemic vasculitis like Henoch-Schönlein vasculitis, systemic lupus erythematosus, polyangiitis, amyloidosis. These are uncommon, but these must be excluded. Occasionally, post-streptococcal nephritis may lead to a picture of nephrotic syndrome, and again, rarely in our country, IgA nephropathy. Now, if we suspect these conditions which are clinically obvious and by laboratory means the diagnosis can be confirmed, if we suspect these, then nephrotic syndrome needs further careful evaluation, and almost certainly a kidney biopsy will be necessary. So, these patients should be referred to a pediatric nephrologist. Now, idiopathic nephrotic syndrome, this is the commonest form which we see. Broadly, we divide this into two groups. One is the steroid responsive, which is minimal lesion type, and the other is steroid resistant, and which is mostly non-minimal. The former is more common between 2 and 6 years, while the steroid resistant type is seen often in older age. The steroid responsive type, boys are more oftenly affected, ratio being like 2.5 to 1, while in the steroid resistant it can be equal distribution. In the steroid responsive type, hematuria is absent, blood pressure is normal. The steroid resistant type may have hematuria and hypertension. Kidney function is normal in the former, but it may be impaired in those who have steroid resistant type. And serum C3 may be normal in steroid responsive, and it may be reduced in the other group. Now, the former is much more common than the latter. At the initial evaluation of a child, of course, we look at the age and sex, we measure the blood pressure very carefully, examine urine for microscopic hematuria, measure the blood urea and creatinine levels, serum C3. The assessment of these parameters will indicate if there is a likelihood of minimal change in nephrotic syndrome or otherwise. It is not necessary to carry out many more tests and extensive imaging. Now, briefly talking about the non-minimal lesion nephrotic syndrome. This is a heterogeneous group, and nowadays, recently more genetic abnormalities are being detected in these conditions. Occasionally, you have a familial form. Underlying histology are three commonest ones which seen are focal segmental glomerulosclerosis, mesangial proliferative nephritis, and membranoproliferative. Of course, we know that the morphological similarity does not imply a common etiology. Gene mutations I briefly mentioned, the NPHS1 gene and NPHS2 genes are being detected now, the former in the congenital nephrotic syndrome of phenotype, the latter in familial nephrotic syndrome, which has an early onset. These patients are steroid resistant, and there is often a rapid progression to renal failure. And the gene mutations sometimes are also seen in sporadic steroid resistant nephrotic syndrome. Again, if non-minimal lesion is suspected on clinical and lab evaluation, the child should be referred to a nephrologist, because again renal biopsy may be necessary, and in these patients we may defer using prednisolone. An example of a non-minimal lesion nephrotic syndrome, 11-year-old girl developed respiratory infection. 4 or 5 days later, facial edema, blood pressure was normal. Urine examination showed 3+ protein, RBCs plus, no cusp. Blood picture showed albumin 2.9 gram, cholesterol 280, urea, creatinine, AS low titer, C3 were normal. She was given 4 weeks of prednisolone 2 milligram per kg without any benefit. So this is steroid resistant. After 4 weeks of prednisolone treatment, she had persistent 3+ proteinuria. She had mild cushinite features, facial edema, blood pressure has increased. We did carry out a biopsy here. We showed mesangial proliferative nephritis and IgM deposits in the mesangium. Shown here showed areas of mesangial proliferation in the glomerulus. Now, this child was treated with pulse methylprednisolone, 30 mg per kg, 5 doses for alternate days. There was about 50% reduction in proteinuria and rise in serum albumin to 3.2 milligram per dl, 3.2 gram per dl. So, in fact, there was some response, but not totally. So, we tried cyclosporine 4 mg per kg per day with alternate day prednisolone, and partial remission was maintained, but not a complete remission. So, in these cases, the long-term prognosis is guarded and not very certain. We talked briefly about the steroid resistant nephrotic syndrome. I mentioned these patients are a minority. They will be about 20-30% of all patients. The definition is that these patients, after receiving full dose of prednisolone, which is 4-week daily treatment and 4-week alternate day, they continue to have heavy proteinuria. We exclude that the dosage has been given, compliance. We exclude infection, we control edema. But after that, if the child continues to have proteinuria, we label them as steroid resistant. And I mentioned earlier, they constitute about 5 to 10% of all idiopathic nephrotic syndrome in children. Biopsy may show minimal change in some patients, focal, segmental, glomerulosclerosis, mesangial, proliferative in others, and rarely other lesions. Now, treatment of these patients as a group, the patients who do not respond to prednisolone, is empirical. There are no clear established regimens. What we do is we try with the pulse IV methylprednisolone, oral or intravenous cyclophosphamide, then sequentially perhaps cyclosporine A and tacrolimus. Failure of these agents, we use non-specific measures. These may reduce proteinuria to some degree. This is the use of ACE inhibitor and angiotensin II blockers. We treat hypertension, control BP very strictly. We control hyperlipidemia. But the long-term prognosis in these patients is not very clear, is certainly not very favorable. Steroid responsive nephrotic syndrome, and this is the majority of idiopathic nephrotic syndrome, perhaps about 90% that we see. And this is the major problem seen by us for the long-term care. 90 to 95% of idiopathic nephrotic syndrome are steroid responsive and presumably minimal change. The etiology remains unknown. They have variable long-term course, but eventually, in the most cases, there is a complete recovery, and expert management is needed to avoid complications and any associated morbidity. Initial management is that we tell the family, the parents about the condition, we explain the problem because they are bombarded with the misinformation and all kinds of advice that try that medicine, try homeopathy and so on. We treat the child if he has an infection, we control edema, and then institute prednisolone regimen. The initial regimen is 2 mg per kg per day in 3 divided doses for 6 weeks, followed by 1.5 milligram per kg alternate days for 6 weeks. So 6 plus 6 weeks treatment. Following that, we taper off alternate day prednisolone over another 3-month period. We should explain the need for high dose treatment because very often the moment the child is better, they stop treatment. Explain the need for high dose treatment and inform the expected side effects. Side effects are cushingoid features, obesity, pain abdomen, occasional vomiting, obesity, increase in hair, and occasionally hypertension. We must explain these that they may be expected, but these are easily manageable. Occasionally, a child may have behavior problems. Again, these are manageable once the parents understand. They must be reassured, and it's often useful to give them some sort of a literature. Otherwise, they will seek advice here and there. They consult internet and so on. Booklets these are available in English and other languages, and these can be given to them. They can read this and they're reassured reading all this. General care of these patients is that we do not impose unnecessary dietary or physical restrictions. We allow a fairly liberal diet, normal activity, normal schooling. The parents are taught how to test the urine and they keep a record of that, keep a diary of the events. At the same time, we must explain the likely course of disease because in most patients, once you stop treatment, there will be a relapse of the condition. And they ask when the disease will be totally cured. This is something which is not predictable. We cannot tell the long-term course as to how many times the child will have relapse, but explain everything and prevent misinformation. Subsequent course is that after stopping treatment, most children will get to relapse, and many of these get an occasional relapse, maybe 1 or 2 in a year. Sometimes more frequent relapses, like maybe 3 or so in 1 year, and occasionally they are steroid dependent. This means that they need high dose of prednisolone to maintain remission, and these are difficult to manage. Relapses may follow. Usually, in fact, follow upper respiratory infection, cold, virals, and transient proteinuria that may happen with a cold or cough is not significant. Now, treatment of relapse is that we can detect relapse early if the parents have been testing urine. So the moment urine becomes like from nil to 1+, 2+, 3+, we are cautious that it may be relapse. And if there is any associated infection, we treat that accordingly and observe. We can wait for a day or so and keep testing. But if the edema develops, even mild edema develops, or urine protein remains 3+, 4+ for a few days, then I think we have to start treatment. And treatment again is daily regimen unless the protein becomes free, the urine becomes protein free, and then alternate day for 4 weeks and we stop treatment. If we treat relapse early appropriately, then the normal routine of the child will not be interrupted. He can continue going to school, has his normal diet and everything. Now, these are the other problem that the child who gets frequent relapses, and these are like more than 3 or so in 1 year, or sometimes we stop treatment, there is a prompt relapse. Now, these patients are managed initially with a low dose of prednisolone given for a longer time, maybe 6 months to 1 year, and this is a small dose on alternate days, not daily dose. And we monitor the growth, means certain that there is no significant steroid toxicity. Now, if the alternate day regimen is long-term, alternate day is not beneficial, then we try other medications. And these are listed here. Initially, we can try levamisole. The dose is 2.5 milligram per kg alternate day long-term. Failing that, cyclophosphamide 2.5 milligram per kg per day for 3 months. Then other agents like cyclosporine, mycophenolate, tacrolimus, and so on. These are given like sequentially in a way, because initially we try drugs which are not so toxic and safe, well tried, but some patients do not respond to these drugs and they need further drugs like tacrolimus. But it needs a lot of experience and judgment to decide their appropriate and judicious use, because all these medications have some toxicity and some risk. An example of a child who was steroid dependent. This was a 3-year-old boy with nephrotic syndrome. There were no unusual features. He responded promptly to prednisolone, 6 weeks plus 6 weeks, but relapsed within a month. Responded again, but alternated regimen, but again it was no beneficial. Levamisole was not useful. We gave cyclophosphamide for 3 months, standard course, and he was in remission for 4 months. Biopsy here showed minimal change. In view of the non-response, we put on cyclosporine, and prednisolone gradually stopped. Cyclosporine was given for 2.5 years, and the relapses were treated with short course of prednisolone. He developed severe hirsutism, with the result that he almost stopped going out of house, stopped schooling. We put on tacrolimus. He was well for 2 years. These are the difficulties in management, but he has been controlled now. He remains normal, and hopefully he will get a permanent cure. Now, if the child does not respond well to cyclosporine and tacrolimus, there are other situations like we can combine with mycophenolate and discuss the hazards and benefits. But it is important to reduce proteinuria, because persistent heavy proteinuria by itself may cause damage, and discuss all these problems with the parents, explain the outlook. Biopsy shows again lots of proliferation, lot of changes in the lobules. Now, it's very important to look for complications in nephrotic syndrome and try to prevent and control them. Complications are massive edema, infections, hypovolemia, thrombotic phenomena, and behavior problems. Edema, we ensure that more than mild edema should not be taking place. Massive edema indicate there is some problem in the management. The family has not been following management properly, or there is something going wrong. I think these can be controlled with drugs like Lasix, aldactone, metolazone. Occasionally, a child has very massive ascites and a very low serum albumin levels, and he may require albumin infusion. But again, I emphasize that mild edema can be controlled easily with simple drugs, and it's not good to see a child with massive edema and ascites. Something like this picture here. All this is very preventable, provided the family understand and try to bring the child for medical treatment early. Infections with careful management, serious infections are uncommon, but a child should be adequately immunized. We try to keep the child in remission and prevent edema. Detect early and treat aggressively, because these patients may be immunosuppressed. So infection must be detected early and treated very aggressively. Hypovolemia, this is a complication we see sometime in nephrotic syndrome. An example here, 6-year-old boy, steroid responsive nephrotic syndrome. He was off treatment for 6 months, developed cold, fever, which caused slowly increasing proteinuria. The test showed 2+ protein for 12 days. He had diarrhea for 1 day, then complained of severe pain abdomen, lassitude, lethargy. He was afebrile, oral intake was poor, he was oliguric. On examination, he had just mild edema over the face and legs. Abdomen, there was no ascites, no mass, no tenderness. Extremities were cold with poor capillary filling. BP on the lower side, tachycardia, hemoconcentration, hemoglobin 15.6, blood urea marginally high, 64 milligram per dl. We suspected hypovolemia, and we gave IV albumin, and there was rapid improvement. It is important to understand that hypovolemia can mimic acute abdomen. So all this is very easily correctable provided you suspect and examine thoroughly. Treat relapse early, prevent gastrointestinal infections. Upper respiratory infections, virals cannot be prevented, but the diarrhea and vomiting can certainly be prevented to some extent by careful management. Thrombotic phenomena again are seen occasionally. This was a 5-year-old boy, steroid dependent nephrotic syndrome, in remission on prednisolone on 20 milligram alternate day for 4 months, mild cushinard features, normal blood pressure, complaint of headache, frontal, persistent, severe, had papillary edema and likely to be pseudotumor cerebri. That was the tentative diagnosis. CT scan showed no abnormality, but MRI showed sagittal sinus thrombosis. These episodes are not uncommon, but often go undetected. And we advise that deep vessels should not be punctured. Suspect if asymmetric edema, if one limb is edematous, suspect there may be venous thrombosis. The child should be well maintained with hydration. If there is underhydration or diarrhea, vomiting, corrected carefully early. Cerebral sinus thrombosis may be confused with CNS infections. So one has to look at all these carefully, and prompt anticoagulation will control that. Now, eventual outcome in nephrotic syndrome, most patients who have steroid sensitive nephrotic syndrome will eventually completely recover. And we emphasize this again and again to the family. But the course of disease is not predictable. We cannot tell as to how many relapse the child will have, what will be complication, and when will the disease be totally cured. But with the management and families' understanding, cooperation, complications can be avoided. Child be maintained in remission as long as possible. Avoid iatrogenic problem. We must avoid drug toxicity and problem that we may create. The family need constant reassurance and emotional support. We have to explain repeatedly, give the message that child will recover. And expert joint management by pediatric nephrologist and pediatrician for every minor things. They need not come to a pediatric nephrologist. They go to their pediatrician who will examine and who will keep in touch, who will consult the pediatric nephrologist. The final message is that it's a common condition. A fraction of the patients, maybe 5 to 10%, have some complex problems. 5 to 10% are steroid resistant, and that's a much more difficult problem. But the majority like 90%, are steroid responsive. They do very well, and they will eventually recover completely. Thank you.